this is a journey of 20 years with a very challenged eye. I will go fast a little bit. It's a story of 1999, and it's about a young novice surgeon who dared to do a challenging case in a one-eyed patient. And this was the one-eyed patient, and this was the surgery.
Volume.
So this was the surgery, and it was an uveitic cataract. And when I did the surgery, I removed off all the synechia that there was, and it was a mid-dilated pupil. So I did think that, yes, I would get a good rhexis, and I did stretch it a little, because in all these uveitic cataracts, it's important to stretch it, because that, in fact, releases some amount of the tension of the fibrosis that has gone on onto the pupil. And you can see that it is an adequately done pupil, 6 millimeters, 6.5 millimeters, and I'm able to get nice rhexis without putting any hooks or devices, and that completes it. Please remember that I was quite a novice surgeon at that point of time. And then I'm doing the nucleus management and taking off the nucleus, but then this becomes difficult, and the pupil is shrinking, and it's a thick plate of epinucleus which I cannot get out, and so I've resorted to a hydrodissection, and unfortunately the iris is coming out, and it's becoming a little difficult for me, but I go in from the side port and tweeze off the iris from the main port, which has prolapsed. And then, of course, in the center part, keeping my phaco needle right in the center, I'm able to do off a good nucleus management, and I place a 3-piece hydrophobic intraocular lens in the bag. So this done, that becomes the end of the surgery, and we do not have much mishaps. But as with all uveitic cataracts, there are problems, and this one-eyed lady, a very, very nice person, she followed up with me. But there was repeated inflammation, recurrent hydrocyclitis. At one point of time, CNVM developed. We used anti-VEGFs multiple times. And ultimately, despite there was pupil obstruction and Elschnig pearls came on, and repeatedly we had to do capsulotomy. And finally, we had hardly any view. The vision had dropped, and we had to do something about the obstruction of the vision, and this was what it was. So this is the last part, and it's just about a 1-minute video, and this is what had happened. It had obstructed the visual axis, and we had to do something about this. So we take this patient up, and we need to be very careful because it's a fibrotic bag, it's a one-eyed individual, and high molecular weight viscoelastic is being used. I'm trying to take off as much of synechia as possible, and trying to create basically opening between the edge of the pupil and the anterior capsule, which is fibrotic. So once I do this, then I have some space wherein I cannot actually manually separate out. It will never manually separate out because it's too thick a synechia. What I will have to do, and the bleeding has started occurring, I'm placing in viscoelastic as much as possible and trying to create that space. Only that space is important, and then the vitrector comes in. And that's the most important part of the whole exercise, which is simple, but if it is not handled well, it can become quite difficult. And at this point of time, it's not only the fibrotic bag which has shrunk, the anterior capsule which has shrunk, but also I'm taking off the collarette of the pupillary margin, and thereby ensuring that this pupil will not shrink. And I'm trying to see to the fact that we just have an adequate pupil, no use of devices at this point of time is required. And we try and keep it, and as you can see that it is quite nice and pristine while we are doing the whole procedure. But of course, the bleeding can occur, and therefore a tamponade will be warranted as and when required. So with this done, and you can see that the tamponade is important, and we need to wait a little to see that there is no hyphema. So this is the post-operative picture of this patient, and thank you very much for your